by way of background, neurocognitive and psychological impairments are actually the most common morbidity in complex congenital heart disease. In the past, for example, survival was not nearly so good, and actually 90% of infants with critical congenital heart defects did not survive the first year of life. What's happened now is as survival has gotten better and better, patients with critical congenital heart disease are with us. They go to school, they grow up to be adults with very high probability of survival. And so we've seen that many have neurocognitive or psychosocial challenges, and those include problems with motor function, like walking, writing, expressive language, trouble with academic achievement. There's a higher rate of need of special educational services and more persistence of neuropsychological and behavioral deficits as people grow into adulthood. And because of that, the American Heart Association wrote in both 2012 and 2024 scientific statements. That's when you bring experts in the field together to write about a problem and make some suggestions. And those guidelines, or actually statements or recommendations, suggested that all children with congenital heart disease should have an evaluation for their development, not just a screening that a parent fills out a questionnaire, but a real evaluation between 12 and 24 months, 3 to 5 years, and then as needed again, 11 to 12 years, and that early intervention also be prescribed so that when a child goes home from the hospital after surgery, for example, you're able to give them physical therapy and kind of help parents teach parents how to aid the development of a baby. In the most recent American Heart Association statement, which was in 2024, there were 3 categories of risk. The first category was children with open heart surgery in infancy. The second was anybody who is always blue. And the third were children who had any kind of intervention at any age less than 18, but they also had other risk factors for neurodevelopmental problems, including even having low socioeconomic status, for example. So the way that this study then was set up is that we wanted to look to see in publicly insured patients who were in the high-risk group of having cardiac surgery at age less than 12 months, and who were followed for as long as age 5 years, to see what percent had different types of neurodevelopmental and neurologic disorders, the types of healthcare utilization that we had that were related to those disorders, and then very importantly, the cumulative percentage by age 5 years who had at least one diagnosis of a neurodevelopmental disorder, and also at least one type of neurodevelopmental evaluation or therapy. We then also looked at what the independent risk factors were for an earlier time to the first neurodevelopmental diagnosis and the first neurodevelopmental evaluation or therapy. What we found, and I'll do this relatively quickly, is that many children had use of various kinds of neurologic and developmental testing. So for example, any kind of neuroimaging test, almost 8% had some kind in the first year of life, and then it went down every subsequent year to age 5. If we looked at the risk factors for an earlier diagnosis of a neurodevelopmental disorder, the risk factors included that the more complicated your surgery was, the more likely you were to have an early diagnosis. So those kids who had the most complex surgery done, most complicated for the surgeon, they're usually in the hospital for longer, they were the ones who seemed to have the earliest diagnosis for a neurodevelopmental disorder. We also saw that Hispanic or Black race, ethnicity was a risk factor compared to white children for an earlier diagnosis. And then similarly, if we look at independent risk factors for the time that it takes to the first utilization, meaning how soon a service is given, the risk factor was once again more complicated surgery, and also, well, that was the biggest, strongest risk factor. I think perhaps the most striking finding was that in the first year of life, if you look at the cumulative presence of having any neurodevelopmental diagnosis or any type of neurodevelopment utilization or physical therapy, occupational therapy, speech and language, that in the first year of life, almost 30% of children had at least one neurodevelopmental diagnosis, and almost 64% of children had some form of utilization. By the time you got to 5 years, those numbers were that half of children with surgery in the first year of life had at least one neurodevelopmental diagnosis, and almost 83% had at least one utilization. We concluded from this that the overall prevalence of neurodevelopmental diagnoses and use of services was high. What we found was that the rate of screening what a pediatrician does in the office in every child were very similar in these patients to what was found in general pediatric samples. But the very few children, and you could tell this from the billing code, these are all children who by American Heart Association recommendations should be receiving a formal neurodevelopmental evaluation. Very few children had that evaluation, and so these kids weren't really getting the services that they needed. And I think we concluded that we need better implementation of the suggestions of expert committees so that routine developmental evaluation is actually incorporated into the evaluation of children with high risk congenital heart disease, or congenital heart disease that's at high risk for neurodevelopmental sequelae. Although almost 56% had neurodevelopmental screening, fewer had any kind of psychological or neuropsychological evaluation that was comprehensive and was more typical for what is recommended by the American Heart Association. So 6.6% had a psychological or neuropsychological evaluation, and 8.5% had a comprehensive developmental evaluation. 100% of those children should have had one or the other.